So thanks a lot for joining us today. I know it's the lunch hour for many of you. Today's webinar is a little bit different. For any of you who may have participated in our Perinatal Regionalization 101 webinar, we're going to do a quick overview of regionalization for those of you who may not participated in that webinar. They were offered in March, April, and May, and that recording is still available. If you'd like to listen to it, you just need to go to MoCares4Babies.com. I'll put that up. You'll see that web address on a few of the slides throughout the presentation. So there's a link on the website to the original Perinatal Regionalization 101 webinar that will link you to the YouTube video of it. So we're just going to start out today with a quick overview of what kind of questions I hope to answer for those of you on today's webinar. So here are some of the things that I'm going to talk about. If there are other questions that you have, any burning questions, feel free to type them into the question box, and I'll try and answer those as well. I by no means consider myself an expert on regionalization, other than the fact that I've been working on this for approximately 2 years here in Missouri, and the information that I've absorbed through that process. So I'm sharing everything with you that I know to the best of my ability. And if there are questions that anyone has that I'm unable to answer, we will definitely be following up after today's webinar. So as I mentioned, we're going to start off with just a really brief overview of what regionalization is. And then these others are some questions that I've gotten fairly regularly as we've been working on this, and I've been traveling through the state talking to people. So we thought it'd be great if we could kind of answer them all in one place. And again, please feel free to chat out here in the chat box any other questions you'd like to see answered. So just to start off, we'll just do one kind of brief slide on regionalization. And so what is up on your screen right now, some of you may have seen this in our handouts that we were utilizing this year as part of our outreach and education. So this is just a map of which states are regionalized right now for perinatal care in the United States. So those that are purple in the map have regionalized with by putting in place an actual statute. The ones in pink, we're saying, are regionalized without statute. So in our communication with the state, all the states in pink, what we found is that they implement the components. They're able to acquire state funding to support a regional system. They maybe do some, but not all, pieces of regionalization, but they recognize themselves as being regionalized. There just simply isn't a statute on the books, so to speak, in these states. So this is the national landscape to the best of our knowledge at this particular moment. So when we talk about perinatal regionalization, by definition, what we mean is a comprehensive, coordinated, geographically structured system of designating where infants should be born to assure risk-appropriate perinatal care is available for both mom and baby. By no means is this a new concept. It was originally introduced in a 1976 publication called Toward Improving the Outcomes of Pregnancy. So this publication came from the March of Dimes and the Committee on Perinatal Health. And it was the first time we find mention of regionalization in the literature. Initially, when the concept of regionalization was brought forth, the idea was, or the concern was, that we saw low birth weight, very premature babies dying because they were not receiving risk-appropriate care. So from the beginning, really, the focus of perinatal regionalization has been on reducing infant mortality. It's evolved somewhat over the past nearly 40 years that you will see that states have been regionalized. that no longer is it just focused on infant mortality. You'll also see a focus on reducing long-term morbidity associated with babies being born too small and too early. And there's also an emerging emphasis just in recent years on incorporating maternal outcomes. So looking at pregnancy-associated mortality and morbidity that we see associated with near misses. So it has evolved as a concept over the past 40 years. And just looking at this map to give you an idea of what some of our neighbors have done, Illinois and Iowa regionalized very early, so around 1976. Texas was the most recent state to regionalize, to my knowledge. They passed a statute in 2013. And you'll also find other states, such as Michigan, which was originally regionalized, but deregionalized in the 1990s, and they are now trying to re-regionalize. So there are some states that kind of fall into that category. All right. So let's talk a little bit about the data. One of the handouts that I've posted for you, I believe it is titled Perinatal Regionalization for Very Low Birth Weight and Very Preterm Infants. This was a meta-analysis that was conducted in 2010, and it looked at over 40 peer-reviewed journal articles that had been published on regionalization since the late 70s. And here are some of the outcomes when they did the meta-analysis. Some of these outcomes are shown here on your screen. So when they looked at very preterm babies born more than 8 weeks premature, their chance of dying increased by 55% if they were born in a hospital without a NICU. The odds increased to up to 80% when you're looking at extremely low birth weight babies, so those born weighing less than 2.2 pounds. So if you want, I really recommend that article if you want some more information or just kind of to dive into that meta-analysis and see the details. It is posted there for you. So as I mentioned, a lot of this ties back to infant mortality. And there has been an emerging or re-emerging emphasis on perinatal regionalization in our country. And we see that coming out of several infant mortality initiatives that are taking place in the U.S. One of those is the COIN, which is the Collaborative Improvement and Innovation Network to Reduce Infant Mortality. I believe that's coming out of the Health Resources and Services Administration. And they are recommending states focus on six areas for improvement of infant mortality, and one of those areas is regionalization. So there's a lot of renewed interest in this decades-old concept. And part of that can be attributed to the fact that when we look at infant mortality rankings, we as a country really do not fare well when we're compared to our peers, our counterparts. So what you'll see up on your screen right now is a graph that I took out of, let's see, I posted it up here for you guys. So for those of you who maybe like to geek out with me, this came out of a recent, I believe it was a late 2014 journal article from the CDC, and I had it sitting here, and if you saw my desk, you'd understand why I suddenly can't find it. They compared all of the states that participate in this Organization for Economic Cooperation and Development, which in total is 29 countries. And so out of these countries, 26, they had data to compare. And when we looked at those 26 countries, the United States comes in last with infant mortality. And so even when they tried to do some controlling, for other associated variables, we tend to be towards the bottom of the rankings. Interestingly enough, when, infant mortality is often looked at as an indicator of a country's prosperity and health, and for that reason, the CIA, and yes, the Central Intelligence Agency, actually monitors infant mortality rates for 224 countries. And looking at 2014 data, for those 224 countries, I was shocked to see that the United States ranks 55th in the world. So there are 54 other countries that have lower infant mortality rates than we do. And what this graph shows, this figure that I have up now, is that among industrialized nations, we tend to have one of the highest infant mortality rates. So this came out of a National Vital Statistics report. Now that I see that. And it was very interesting, and I'll just say this and then we'll move on to things that are more interesting. But so what they found, the results were that U.S. infant mortality rates for very preterm infants, so for those of you who are on today's call and work in the NICU, so when we looked at infants 24 to 31 weeks of gestation, our infant mortality rates compared very similarly to those of all of these other countries listed. However, I found this sort of shocking. When we looked at infant mortality from 32 to 36 weeks of gestation, the United States was second highest among the 26 countries that they looked at data for. And then when we looked at infant mortality for 37 weeks gestation or more, we come in with the highest infant mortality rate. So I found that to be somewhat shocking when looking at this data. And so when comparing it to Sweden, which is often used as kind of a benchmark, as we can see, they have a very low rate. They noted that 39% of our higher infant mortality rate was due to a higher percentage of preterm births here in the United States. So that's 39% of the variability. Another 47% was due to the higher infant mortality rates we see at 37 weeks and above. So if we could just focus on those two factors and get down to the levels that Sweden is at, the paper concludes that we would reduce our infant mortality rate by 43%. So that's 7,300 infant deaths averted annually. So this paper is up here for those of you who found what I said so intriguing you want to read the whole thing yourself. And I promise one more quick slide on state infant mortality rates. I don't know what I just did. Let me see if I can go back. I don't know what happened here. It's missing. All right, so state infant mortality rates, I will just tell you what they are. So this is 2013 data. So in the United States, using 2013 data, we had 5.96 infant deaths per 1,000 live births. The lowest, if anyone knew this, I would happily give you a prize, was Iowa, with 4.14 infant deaths per 1,000 live births. Mississippi is the highest at 9.65, and Missouri comes in at 32nd place. So from our 2013 data, the CDC put us in 32nd place with 6.52 infant deaths per 1,000 live births. So that was 491 infant deaths in 2013. Just to note, there is a significant racial disparity when we look at the data. Now, Missouri's disparity very much mirrors the disparity for the United States. In Missouri, the infant mortality rate for white infants is 5.61 infant deaths per 1,000 live births, and it's more than double that among black infants. It is 11.77 deaths per 1,000 live births. So a pretty shocking difference between infant mortality rates between white and black babies. So I promise that is all of the background that I was going to provide in terms of looking at infant mortality and why it's still such an issue for us here. I am just quickly checking the question box. Oh, good. So the slide is on the PDF. Thank you, someone. I'm glad I loaded the right slides up. So that was really the only information I'm going to provide. If you wanted more information around perinatal regionalization as a concept, I really recommend the Perinatal Regionalization 101 webinar that we have archived. So what I wanted to move on to is why we need legislation, because I get this question all the time from folks. And so there's really kind of three reasons. So the first one is that voluntary systems don't work. And we have evidence of this. Arkansas, so our neighbors to the south, implemented a voluntary system, and in an evaluation of data that they collected from 2001 to 2006, that was the conclusion they came up with, is that voluntary did not work because some hospital systems and facilities selected not to participate. I recognize that no one likes a mandate or anything that sounds like a mandate. I know I don't like it in my work. I don't think anyone does. And no one likes a mandate in the General Assembly. If it smells like a mandate, looks like a mandate, walks, talks like a mandate, they will certainly let you know that they're concerned. However, we know from 40 years of data that in order to be effective, we need all Missouri hospitals that take care of pregnant women and infants to participate in the perinatal regionalized systems perinatal care. So we know if we left it voluntary, there would be hospitals that selected not to participate. And then neither the facility, the healthcare providers, or the patients are going to reap any of the benefits that a system, perinatal system, has to offer. So that's reason one. Let's see, for the original, I was just looking, we had some questions. All right, and I will get to those questions shortly. So second, we need the means to start building an infrastructure. So there's one thing we know from talking to our peers who are working in regionalized states, and that is, you know, that we have a starting point, and we need to start building an infrastructure. I have become fond of saying Rome wasn't built in a day, and our regionalized system of care won't be either. What this legislation does, and we're going to go over it in more detail, just the specifics of it, because I think there are a lot of concerns about it, what that legislation says or doesn't say. But this allows us, this legislation that we had during the 2015 session and that we'll see again during the 2016 session, allows us to start moving Missouri forward in building a regional system. So it sets some deadlines of when certain work has to be done so that we really don't stagnate in moving this forward. And one of the participants this year, a physician that I work with, made the comment that this is not legislation mandating practice. It is legislation that provides medicine, and by that he meant both doctors and hospitals, the infrastructure required to improve outcomes for Missouri's babies and mothers. So, and that really is the intention behind this legislation. The third reason is legislation legitimizes what we're doing. We could go out today, those of us who believe in this concept, and start, you know, rallying to create a regionalized system of care. But the truth is that regionalization as a concept isn't cheap, but it is cost effective, and we know that for sure. And we know that once we've fully conceptualized what regionalization could look like here in Missouri, that we're going to need to pursue funding for the regional system. And creating a system that resides within statute in Missouri lends credibility to the issue. And that credibility is really essential for us to obtain funding for the system. So I'm just going to check to see if anyone had anything in chat or questions. All right, so just a couple questions that I've had. Need the address to get the archived original presentation, and I will give you the address for the MoCares4Babies website. It's on a slide later on, and that's where it's archived. And the original presentation, yes, it does contain the full definition that I gave at the start of the presentation. I just put up here for you guys, just so you know, I didn't make the slides into a PDF, so you actually have my slides with all the notes, which I'm thinking is okay, but you'll find the definition in there as well. So if you print out the notes pages, you can see all of my comments. So, all right. So we're going to move on from why we need the legislation to what it actually does. And there was a lot of concern over the last session about what this legislation does and does not do. I may have had conversations with some of you. A colleague and I, were out presenting at staff meetings at hospitals and talking to administrators, hospital administrators, and physicians and nursing staff about this concept and the intent behind this legislation. And as I mentioned in the last slide, it helps us establish an infrastructure by essentially doing two things. Number one, it creates a Perinatal Advisory Council, and this is a group of experts in maternal and infant health that are charged through this statute with designing the system of what regionalization could look like here in Missouri. And then the second part is it moves us from a process of self-designation to a formal review process for determining each facility's capabilities. So right now, any hospital that delivers babies or takes care of infants in a NICU, everyone is self-designating themselves as level 1, 2, 3, or 4 based on the AAP levels of neonatal care. There isn't any sort of official review process in place, and one of, I think, the core foundations of regionalization is going from that self-designation to a more formal review process that helps us better understand the lay of the land in Missouri. So what hospitals are capable of doing for moms and babies in within their region. I also want to specify, because this also came up, that the idea behind this legislation isn't to put any hospital out of the business of delivering babies. We are already losing birthing hospitals here in Missouri. Since I've started with the March of Dimes, I can think of at least 4 hospitals that discontinued labor and delivery services. And if you look at a map of the birthing hospitals in Missouri, we can't afford for any more hospitals to stop delivering babies, particularly when we get out into some of our rural areas. Women are traveling, I've been told, up to 100 miles to get to the closest facility that offers labor and delivery services. The idea is that we just have a better idea of where these hospitals stand in relation to the levels of neonatal care and the levels of maternal care, which I'll talk about in a minute, and to start creating networks of resources so that we're making sure that moms are getting to the closest hospital that can provide the right level of care for them and their baby. So really, this is all it specifies. It specifies these 2 particular pieces. I was just checking the questions again. So the handouts should be on the pull-down screen on your right-hand side. It allows you to raise your hand, to write in a question, to chat, and one of the little breakouts is a handouts box. So that is where you should be able to download any of the different handouts that I've loaded up. So that is what it does. Let's talk a little bit more about the Perinatal Advisory Council as it was written into the legislation. So the legislation was very specific for 2015 about the responsibilities of the Perinatal Advisory Council. It specified who would sit on the Perinatal Advisory Council. There are approximately 20 seats on the Perinatal Advisory Council to be filled by groups such as the American Academy of Pediatricians, the American College of Obstetricians and Gynecologists, the Association of Women's Health Obstetric and Neonatal Nurses, the National Association for Neonatal Nurses, maternal and infant health coalitions in the state. So it's a fairly broad based membership, and we tried to give everyone, or the legislation tried to give everyone a seat on the council so that their voice would be heard. So part of what the legislation says is that this council, once they're determined, will seek broad public and stakeholder input before making recommendations on the division of the state into neonatal and maternal care regions. So there is going, while we're always collecting feedback, and you're welcome at any time to send your personal feedback, your facilities feedback, there is also going to be other opportunities through the Perinatal Advisory Council to provide feedback on how the state should be divided into regions. And then the second part of this is that the council will establish criteria for levels of care. It does specify that those levels will be based upon the AAP levels of neonatal care, which many of you may already be familiar with. Let's see, I think the most recent version is from 2012. Unfortunately, I could only upload 5 documents, so I wasn't able to upload the levels of neonatal care, but I'm happy to provide them to you if you'd like to email me. And also the levels of maternal care, which I did pop up here in your handouts. So those are somewhat newer. They just came out for the very first time this past February, and they're quite specific. This was the first time anyone's taken a stab at creating levels of maternal care, and it was a joint effort between the Society for Maternal Fetal Medicine and ACOG. And it's my understanding from many conversations that in being the first to go at this, that there's wiggle room. And part of what the Perinatal Advisory Council will be responsible for doing is looking at those levels of maternal care and those levels of neonatal care. And I love this wording. It was in the actual statute, but they will take into consideration the necessary variance when considering the geographic and varied needs of the citizens of the state. So that's really the clause within the statute or within the legislation that allows Missouri to make modifications, if needed, to how we interpret the levels of neonatal care and the levels of maternal care. So I often say this is the equivalent in my mind of throwing the wild card during UNO, because there are many ways that we can interpret that specific statement. Hopefully we'll do it in a way that's best for Missouri's mothers and infants. I just want to say going back to number 1, because I forgot to say this. So in seeking input to divide the state into regions, there was some guidance given that they need to look at the geographic proximity of facilities, take into consideration existing hospital systems, insurance networks, hopefully keeping the boundaries consistent for the neonatal and maternal care regions so they wouldn't be carved out differently, neonatal not being and maternal not overlapping. We want them to overlap. And the last thing was existing referral networks and patterns when those referrals are to appropriate birthing facilities. So the idea wasn't to take control away from facilities or physicians in making appropriate referrals. The idea was if you're making those appropriate referrals, that's great. Keep on doing so. But where there are not referrals being made, the system can step in and help do that. This is not going to be an easy task. When this concept was rolled out in 1976, healthcare was a much simpler field. It was a much simpler world. A lot has happened in 40 years. I think so. I think for states today that are looking to regionalize, it's a much more complex playing field than it potentially was for states if they regionalized in the 70s and 80s. I just wanted to reiterate that, and that there's opportunity for you to provide input. So the thou shalt not. The legislation, for all that it did actually specify would be done, there were even more caveats of what the legislation could not do. So it prohibited several things. I also refer to these not as thou shalt nots, but as rumors, myths, and urban legends that I heard during the session. But I just want to make sure everyone was aware of these components being in the legislation. Nothing in it can be construed as modifying or expanding licensure for any healthcare professional. Nothing in the legislation can be construed as requiring a transfer, a patient transfer to a different facility, and nothing could be construed as imposing liabilities for referral or failure to refer. So the legislation is very specific on these specific matters. So I want to stop there, because now we're going to talk a little bit about the crazy legislative session and what happened and didn't happen, just to see if there are any questions about the legislation. So did anyone have any questions specifically about what the legislation may or may not do? All right, so I have one question. Trina, can you please share the various points of view you've had across the state of those who would oppose it? This is a great question. So I literally spent the first 5 months of this year touring the state, listening to everyone who had concerns about it. I think some of these concerns were just covered in the thou shalt nots. There was concern among hospital systems that they would be forced to refer outside of their own system. And we tried to make that clear in the legislation that that was not the case. If you're making appropriate referrals within your system, if you have a hospital that meets the designated level of care that a patient needs, you can keep referring within your system. I think another concern was that from some of the smaller hospitals, that this was a way to, that they felt they were going to lose a lot of their patients. They would be referred away to larger hospitals. And that is not at all the intent of this. In fact, when you talk to states that have been successful in reducing infant mortality and some of the morbidities by implementing regionalization, I think one of the things that they are quick to talk about is the fact that if mom is having a high-risk pregnancy, they do their best to keep mom close to home for as long as possible, even if they have to transfer her for delivery. The idea really was in those states, when we talked to them, that mom's local OB entered into a consultative relationship with a specialist to keep mom close to home as long as possible, because recognizing what a strain it is on families to have to travel long distances for care. So there was a concern that this, I would say that was probably the most predominant concern too, that this was going to remove patients from their local hospitals and send them to the larger facilities that may be away from home. I'm trying to think of any. There's a concern around this taking a lot more time in terms of data responsibilities or reporting responsibilities. I think we may have some data gaps that need to be filled, but for the most part, it's my impression, and this is just my impression from my work in the state, that we have almost all the data we need to implement a regional system through birth and death certificates. We have a pregnancy-associated mortality review. We already have a fetal infant mortality review happening. We have some great data that is already being reported that we could utilize. We need to figure out how to access that data and utilize it to drive decision-making within a regional system to identify quality improvement needs. Those, I think, are some of the top concerns that I heard. I'll let it marinate in my mind and see if I come up with any more. Another question, with regionalization, can designations change from where we are now to a lower level? And if so, could that prevent us from getting referrals or have to transfer out? So I guess I want to start that by my answer to this question by, number one, the system cannot force any hospital, any facility or physician to transfer. The idea behind regionalization is to create a network of resources so that if a transfer is needed, perhaps to a specific specialist, that the network has already figured out where those resources are and can easily help provide referral. But it does not force a facility or a physician to make referrals and transfer patients out. Kind of goes back to those thou shall nots that we just covered. Depending on how often a hospital, a facility was reviewed and any changes made to the levels of designation as they're being used in Missouri, yes, it is potentially a possibility that a hospital could go from a higher level to a lower level if they stopped providing some services. So if, for instance, a hospital, for some reason decided not to have a neonatal intensive care unit anymore, perhaps they weren't going to have a neonatologist on staff, it is possible that they would go from a level 3 facility under AAP to a level 2. It would totally depend upon meeting the equipment, facility, staffing requirements as outlined in those levels of care. It is also the reverse is possible, in that if a facility is currently a level 1, but recognizes perhaps a need in their region for a special care nursery because they see too many babies being transferred elsewhere, if they are willing to invest the resources in making sure that their facility, equipment, staffing, and education meets the requirements for that level 2 special care nursery, they could then be bumped up from a level 1 to a level 2 hospital. In talking to other states that have implemented regionalization, it is the level 2s and level 3s, so those special care nursery versus NICU, tends to be where they see the most play in hospitals changing either up or down. So that your level designation could change. You could also have a different level designation for levels of maternal care versus levels of neonatal care. The easiest example of this would be a children's hospital, which may have a level 3 or 4 rating for neonatal care and perhaps a no rating for maternal care. So there is the possibility that a hospital could have 2 different levels for neonatal and maternal. So I hope that answered the questions that were shared. So in the last 15 minutes we have, I just wanted to talk a little bit about what happened during the legislative session. Let me go back. Okay, so I will disclose to all of you that I have now survived 4 legislative sessions in Missouri. So there may very well be some of you who have more experience with the legislative process on the phone right now with us. One thing I've learned, and I've yet to find anyone disagree with me, is that passing legislation is not an easy task. And if that wasn't enough, the final week of the 2015 legislation session here in Missouri was very atypical. Now, I will say no two legislative sessions are really ever the same. They're a little bit like snowflakes in that way. But it was quite atypical in the Senate this year. So I just wanted to talk a little bit about that. So I'm not sure how in the weeds to get with folks. So if by a show of hands, how many of you feel like you are, raise your hand if you feel fairly comfortable and confident in your understanding of how a bill becomes a law in Missouri. So if you feel like you have that down, just raise your hand. All right, I'm excited when I see hands coming up. I see a couple. All right, just to give you guys an idea, and this is kind of what I expected, we had about 10 out of 40 of you raise your hand. So about a quarter of the folks on the call today really feel like they have a good understanding and grasp on how a bill becomes a law in Missouri. So I think I have it down now, though every session something different happens. But I have given to you guys possibly my favorite handout of all time, and that is how a bill becomes a law. It's called MSH Bill to Law. It's a PDF. And I have it up here on the slide, but you can't really read it. So some of you may be familiar with this. It's a great resource which they happily allow us to utilize. But this is the path to how a bill becomes a law in Missouri. It is complex, and I think the one thing, I recommend you can, if there's ever a bill you want to follow, you can literally print this out and follow along and see where it's at in the process. They did a fantastic job with this. But I think if there's one thing I want you to note from this, it's that there are many opportunities along the path of a bill becoming a law that it can fall off that path and become a dead bill during the session. And if you prefer, if you've ever seen Schoolhouse Rocks, I'm Just a Bill on Capitol Hill. I did put the YouTube link in here for you. And let's see, I see we had some questions pop. All right. So what happened to our bill? The legislation, just so you know, was poised to pass this year. We went into the final weeks of session feeling pretty confident in where we were at with it. Something unforeseen happened in that the Senate got into a filibuster over a right-to-work bill, which is a bill concerning labor unions. I'm not going to get into the specifics of it because it's much more complex and completely off topic for this. But what happened is the Democrats were filibustering this right-to-work bill, and I've been told that while a PQ is common in the House of Representatives, it's only been used 21 times ever in the history of the Missouri Senate. So I believe that 2015, this made it the 22nd use of the PQ. And the PQ, people kept throwing this around. I had never heard of it before. So of course I went to our very reliable Wikipedia. I then, went to someone reliable and made sure I understood this. But PQ is essentially previous question. So someone stopped the filibuster by moving for the previous question. So essentially what that does, it's part of parliamentary procedure. It automatically ends debate and brings the bill, whatever bill they're talking about, up for an immediate vote. And so, of course, as you can imagine, those who were filibustering the right-to-work bill were really unhappy to have their filibuster broken by the PQ. And in doing so, they essentially stalled all work happening in the Senate for pretty much the final 2 weeks of the year. So they brought everything to a screeching halt, and perinatal regionalization was one of 20-something bills that did not get passed through the Senate during those final weeks of session. Typically, they are their most productive. However, that was not the case this year. So our bill didn't pass. We got all the way through the first house, into the second chamber, and we never got up for a final vote. So now what? So the Prematurity and Infant Mortality Subcommittee that worked on bringing up the legislation this year has already met and decided that they will refile the legislation for consideration during the 2016 legislative session. In the meantime, we are going to continue to conduct outreach to hospitals, providers, professional organizations, and any other key stakeholders. The feedback that we receive now from you, from your facility, from your colleagues, over the coming months will be reviewed by the subcommittee and considered when while we're drafting the 2006 legislation. So that is where we're at now with it. We've already started the redrafting process. We had our first conference call this week, and we are, as we go through the 2015 legislation, taking into consideration the feedback we've received thus far. So it will be coming up again. One question I get is, how can my facility prepare or participate? One option I'm going to offer is that I'm happy to come do this presentation, talk through the legislation with your staff. So if you're at a hospital and there's a staff meeting you'd like someone to present at, if you have staff who have questions that need to be answered, whether it's a webinar or an in-person meeting, I'm happy to come and present, as are several of my colleagues from the subcommittee. So that is one option for you. Another option that I'm recommending is to just conduct an internal review at your facility using the AAP levels of neonatal care and the ACOG Society for Maternal Fetal Medicine levels of maternal care as your reference documents, and see where you stand against them. So even if the legislation passes, it's going to take several years to implement this system, which is several years that hospitals have to figure out kind of where they stand and if there are changes that they want to make within their facility to be a specific level. As you are reviewing those levels of neonatal care and levels of maternal care, if there's something that doesn't make sense for Missouri, if you have questions, you have concerns, if you have suggestions on how we can make this document, these documents, a better fit for Missouri, you know, for a more successful regionalized system, please share those with us. There's one thing I committed to in chairing this group, and that is to keep this a transparent process, to keep you all as updated as possible on the work that we're doing, and to bring all feedback to the committee for consideration. So without your input, the committee will move forward with the input that we have received. But you most definitely have an opportunity here to help shape what this system looks like. You work directly with the families in your region, so you know the needs best. I'm always so impressed when I travel throughout the state to all facilities, providing every level of care, of the commitment I see from the facilities and the staff to providing the best possible care for the residents of their community. And this system should support that. It should support providing the best possible care for moms and babies, and in doing so, reducing infant mortality and morbidity, as well as maternal mortality and morbidity. So this is really a unique opportunity for you to be part of building a system that potentially will be in place for decades to come. If none of those other options appeal to you, you can keep up to date. Here's the website where you can find that archived Perinatal Regionalization 101 webinar, MoCares4Babies.com. You can also sign up to receive periodic updates. Right now, we're just sending out updates about once a month. During the session, they're a little bit more regular as things are moving more quickly. if this is something that your hospital wants to be more engaged in, there's work that the subcommittee is doing that you can become part of. You can more actively participate in the work of the subcommittee as we move this forward. Everyone is welcome to participate. Particularly if you support the concept of regionalization, we would love for you to join us as an advocate for this particular initiative. So please contact me if you have any questions about that. So are you a believer? Cue the Beatles music. So hopefully, monkeys. I always do that. Sorry, my coworker just made sure I knew that was the monkeys. So like I said, follow us on MoCares4Babies. We're also on Facebook and Twitter. Sign up for those updates. And if you want more discussion than what you got through listening to me today or typing questions, please contact me. Here is my contact information. And I hope you found today's webinar helpful in terms of knowing kind of what the intentions are and where this legislation stands and what we hope to accomplish with it. And I just will leave you, I guess I'll stop here. We have a couple minutes. Does anyone have any questions? Let's see, I see the question box. Can I send out the levels of neonatal care to everyone? Most definitely. As soon as we get off today's webinar, since I wasn't able to add those, I will happily send those out to everyone who participated today. So we can definitely take care of that. And then just one final thought. FDR, he created the March of Dimes, and I have to say he and Eleanor would have been some great folks to sit down and have dinner with. And I just loved this quote from him. So one thing is sure, we have to do something. We have to do the best we know how at the moment, and if it doesn't turn out right, we can modify it as we go along. That really sums up, I think, how I feel about building this regional system. We're not going to get it perfect from the beginning, but I think the more of us that are working on it together, the stronger it will be. So that is my cheerleader moment for the day. At this point, I am going to see if I can just raise your hand if you would like to ask a question, and I will unmute your line. Otherwise, for the rest of you, thank you so much for joining us today. And if there is ever anything I can do for you, please feel free to use my contact information and reach out to me. All right, I'm not seeing anyone's hand, so thanks everyone for joining us. Have a great day today.